Anil sir, you can unmute yourself, sir. You want to keep you muted, sir?
No, that's okay. I can.
Live. Live.
Will Siddharth tell me to start, ma'am?
Siddharth, it's
Sir,
all.
sir, you are in live. Good to go.
We can start, sir.
I said, hello, ladies and gentlemen. I am very happy to invite you for this IPNA Webmaster Series. It's the first of the sessions, the IPNA Web Series. To teach and learn are two wheels that keep the knowledge progressing. This webinar is in the direction, is in that direction. Dr. Kalevani Ganesan, a pediatric nephrologist for a decade, has brought together a galaxy of international teachers to gift us their wealth of experience and knowledge in pediatric nephrology. The webinar will be webcast all over the world on the IPNA platform. We thank IPNA. Dr. Kalevani Ganesan, as a course director, has done justice to the responsibility entrusted to her. She has planned to have from the beginning to the topmost part of the pediatric nephrology. She says this will be from clinical to acute nephrology and beyond, mind you. So there's no limit. So a lot of wealth coming to you. Now it is for us to enjoy the fruits of our labor. Thank you all for being with us. Have a happy times. Thank you.
Thank you, sir. I thought we will not interfere in the scientific program. So I am just starting the vote of thanks in the initial. Good evening, one and all. Welcome to the first IPNA Webmaster Series. I deem it a great honor and privilege to propose the vote of thanks. First of all, I start by giving glory to the Almighty God for making today's occasion a resounding success. This event on the whole was a dream come true to us. At the end of every hurdle, we have a big reward awaiting for us. And that is the truth. And same way, this COVID has brought us to online platform to make us share knowledge in a better way. I am grateful to the International Pediatric Nephrology Association for creating such a wonderful platform, a platform of excellence, without which academic activities would not have been possible. And I should really admit it's a platform for spreading pediatric nephrology knowledge across the globe. IPNA has recognized our program and endorsed our program and given the 3 months marked in their calendar for us. And Dr. Mehta's hospital, being a teaching institute, have taken it forward by supporting all our academic sessions. I sincerely thank our chairman, Mr. Dilip Mehta, vice chairman, Mr. Samir Mehta, Dr. N. Kannan, our medical director, Dr. Edwin Fernando, senior nephrologist, Dr. Saravana Kumar, our GM and unit head, for making this event possible. I'm proud and privileged to begin my practice at Dr. Mehta's hospital under the mentorship of Dr. B.R. Namalwar and late Dr. M. Jayakumar. My love for pediatric nephrology is being soaked and groomed by the stalwarts in the field, and that keeps the journey going. I'm grateful to them for instigating the fire in me. I'm grateful to all the senior pediatricians, Dr. R. Shanmugasundaram, Dr. L. Subramaniam, Dr. S. Thangavelu, Dr. N.C. Gauri Shankar, Dr. Annamalai Vijayaraghavan, Dr. K. Nedunchalian, Dr. L.K. Prem Kumar for supporting me. I would like to thank Dr. K. Shashidharan, our pediatric intensivist, for fine-tuning few segments of the program. Away from our medical fraternity, away from the Mehta Hospital, my special thanks to Dr. Georgie Abraham, head nephrologist, Madras Medical Mission, for supporting me from my undergraduation days. And I extend my thanks to my own colleagues, Dr. Sudha, Dr. Sukanya, and our fellow Dr. Siji and Pooja. A special thanks to Dr. Siji for her timeless work for the program. Last but not the least, I thank all my family members, my children, who had always been my pillar of support. The strength of any scientific program is having the best of faculties. And we are proud to have them all together for you, for sharing their knowledge. My real thanks to national and international faculties for their contribution. I have always realized children can fall sick quickly, but with good care, they can recover fast and completely. And it's rewarding to see such sick children transform into healthier kids as a result of good care in partnership with their family. And I am pretty sure at the end of this webinar series, you will be giving the best of care to your patients. All talks in our series is clinically oriented discussions, which will enable us to manage better. So without wasting time, let's hear from our experts. Thank you so much. And I'm happy introducing Dr. S. Thangavelu, Director, Pediatrics, Dr. Mehta Hospital, who does not require any introduction. He is a superman for all students. And he is presently a pediatrician director, DNB faculty, and at Mehta's Children's Hospital. He has a very long CV. There is a lot of difficulty in cut shorting his CV. And he has won the Best Teacher Award, Best Doctor Award, and he's an eminent doctor award by Tamil Nadu Medical Council in 2015. Welcome you, sir.
Thank you, Dr. Kalevani. At the outset, I'd like to thank my teachers, Professor B.R. Namalwar, who gave the welcome address. He was the first pediatric nephrologist of the country. After his DM pediatric nephrology, retired from Madras Medical College as a pediatric nephrologist, he started the department long back and established dialysis unit and all the whatever that has been achieved in pediatric nephrology, credit goes to him. He was the first person to start the Department of Pediatric Nephrology in Madras Medical College. Another teacher, Professor M. Jayakumar, is another pediatric nephrologist. Both of them introduced a topic to me. Even though the topic has water, but it generally is perceived which appears to be dry. But I'm sure at the end of this session, most of you feel that it is pretty an interesting topic. From the faculty, we are going to listen to them. Now you see the heap of salt by the evaporation of seawater in the sea industry, Tamil Nadu, India in the East Coast, lot of white, beautiful white salt out. What do you mean by sodium water homeostasis? Homeostasis means stability of the internal environment. There are two components to that. First one is, are there correct share of water in the body? That is total body water, which may range from 55, 60 or 65 of the body weight. Are there compartments? Water streams best to be in the river, sea and waterfalls, not inside the home or in the airport, which happened sometime back when this Chennai was flooded. ICF, ECF and third space, these are the three major spaces. Among the ECF, divided into plasma volume and interstitial space. Who determine this appropriate distribution of water in these two spaces? Thickness of the water by the presence of electrolytes, mainly sodium, which is measured as osmolarity or osmolality. Or in other words, effective osmolarity or tonicity with respect to the cell membrane. Tonicity decides the appropriate ICF versus ECF volume. There are many couples in human physiology: calcium and phosphorus, bicarbonate and carbon dioxide, vitamin D and calcium, sodium and water. Among all this, sodium and water are the best made for each other life partners. They look after each other very well. Sodium balance is decided by water and water balance is decided by the extracellular sodium. What a perfect understanding between these two. This couple, sodium and water, have two life-sustaining dynamic roles. One is maintenance of osmotic balance among the three body spaces. Second is effective circulatory volume, which is the most essential river running inside our body to supply oxygen and glucose to the whole body for all the organs. Relationship between sodium and water are million years old. Nature selects the strongest species, strongest creatures who survives. Here the strength means how best each creature, each living being manages sodium and water homeostasis. We'll see how the sodium water homeostasis evolved during evolution. About 1 million years ago, life originated in seawater. To begin with, what happened was sodium water inside the cell and outside the cell in the seawater, both are equal and similar. So there's nothing much skill is needed to maintain the homeostasis. The problem started when they started moving to the freshwater ponds. These creatures moving to the freshwater ponds doesn't have enough salt. So this hypotonic fluid moved into the cell and the cell started swelling up. They cried and fervently appealed to God. God, I need a rescue from water loading. Do something to help us. He gifted a tuft of capillaries, which are later labeled as glomeruli. They pumped out all the water and electrolytes without the macromolecules and thereby prevented them from water loading. Then the second appeal came from them. They wanted salt and water to be removed at the same time. The God gifted them the proximal convoluted tubules. From seawater, freshwater, they moved to the dry land. Now their request was totally different. They said, God, I'm in water, but I'm in a dry land. I need to conserve water. Please help me. God gave the third gift, loop of Henle. These creatures evolved higher and higher in the evolution ladder. And at one point of time, they reach the highest position in the evolution, like a human being. They keep moving from one environment to another. At this place, they wanted a help to suit different environment. God gave them distal nephron, which were responding to ADH and aldosterone. For example, this high creature like man does not confine himself to one environment. In the daytime, he goes to the desert safari, traveling in a hot environment at 45 to 50 degrees centigrade, loses water and salt through sweat. ADH is secreted, retains more water, and reduces the volume of urine output. Thirst is also stimulated. In the night, paradoxically, he comes back to the hotel and sleeps under the AC room between 15 to 20 degrees centigrade. Now the ADH secretion is switched off and the physiological effect is reversed. So he is totally moving in different environments in the same day. Here comes a distal nephron for help to fine-tune the homeostasis. Depends on the feedback and changing environment and changing needs. This is another precious gift from God as a distal nephron. So nature finally selected the humans for their extreme skill in managing the sodium and water homeostasis with the help of proximal tubules, loop of Henle, distal tubules, and collecting ducts. So far, we have been discussing about the historical, evolutionary, and philosophical aspect of sodium-water homeostasis. Now it's a time to hand over this stage to Professor Anil Vasudevan and Professor Indira Jayakumar, who are going to discuss about the scientific aspect of salt and water homeostasis. Professor Anil Vasudevan is a professor in the Department of Pediatric Nephrology, St. John's Medical College Hospital. St. John's Medical College is one of the prestigious, ethical, and popular medical college in southern India. He is also an adjunct professor, Division of Molecular Medicine, St. John's Research Institute, Bangalore. His areas of special interest: genetics of renal disease, molecular basis of nephrotic syndrome, acute kidney injury, low-cost devices, showing his compassion to the poor people. He is a secretary of Indian Society of Pediatric Nephrology, member of Committee for Competence-Based Syllabus in Pediatric Nephrology, Medical Council of India. He is having high places, he's worked in high places, member of PhD committee in JIPMER, RGUHS, St. John's National Academy of Health Sciences, member of editorial board, Asian Journal of Pediatric Nephrology, webmaster, Asian Society of Pediatric Nephrology. So much of responsibility is holding. Still, most of his students say there is a very calm and balanced person, very silent teacher, like his own special organ, kidney. Over to Professor Anil Vasudevan.
Thank you, Thangavelu sir, for laying the ground for the subsequent two sessions and for your wonderful introduction to this topic, which I'm sure has made it interesting. And thank you for your kind words too. And I would like to also thank Namalva sir and Kalaivani for the kind invite. And we all know that for years they have been conducting this academic program for the interest of not only the residents, but also pediatricians and all the subspecialists. So I'm going to talk on the physiology of sodium and water homeostasis. As Thangavelu sir said, I mean, probably one of the most critical factors that helps us survive is fine-tuning this sodium and water content in human body. But often we are called, or we see children, like for example, a child with nephrotic syndrome, whom you realize has sodium of 128, or a child with liver disease with ascites have a sodium of 130, or it may be a critically ill child in the ICU with multiple tubes having a sodium that has decreased from 135 in admission to 120, or a post-op child who's having hyponatremia with seizures, or a child with a simple acute gastroenteritis with dehydration, and all of them have some form of dysnatremia. And when you see this child, you start wondering what's going on, how do I treat? Because each of these conditions that I've listed have different mechanisms of dysnatremia. And unless we understand the physiology of sodium and water homeostasis, we won't be able to understand what is going wrong that has resulted in dysnatremia. So I'll be switching off the video because sometimes my audio transmission gets affected. So over the next 30 minutes, I will be speaking on the basics of sodium and water homeostasis and understand the physiological basis on which we decide the diagnosis and subsequent treatment. And also in the end, using case vignettes, I will try to connect the physiology with the investigations and the clinical evaluations in arriving at the diagnosis. So as Thangavelu has rightly pointed out, we need to go millions of years back. Life, as we know, started in the sea, which had a steady concentration of salts, and function of the living cells were critically dependent on the constant electrolyte composition. And our ability of our ancestors to leave the ocean required that the ability to carry the ocean within them in form of an internal ocean bathing all our cells constantly in a fluid that resembles the sea. So, and one of the reasons for a successful evolution from the sea to the land has been because of the kidneys. And this concept of homeostasis has been linked to the kidney for more than a century. And it was recognized that the ability of kidney to maintain this internal environment allowed the organism to have some form of a physiological freedom to move into varying environments. As Thangavelu sir again gave example that in the morning you are in some hot outside, and in the evening you come back to an AC room. In morning, probably your diet was very different from what you're consuming in the other times of the day. So this moving into various environments and taking various kind of diets and various amount of fluid, and still maintaining the constancy of the internal environment, the kidney plays an important role. And we must always thank those researchers who helped us understand how the kidney maintains this sodium and water balance. And it is very intricate, and there are many complex layers which made Homer Smith, a pioneer in modern nephrology, say that it is just not that the kidneys make urine, but we should view kidneys as a philosophy itself. The earliest insight into the renal physiology came from the assiduous study of anatomy, and to a large degree of anatomy by Bowman, by Jacob Henle, after whom the loop of Henle is named, because to a large degree, renal function follows structure. They meticulously delineated and identified the various structures and components of kidney, right from a simple organism to the to complex organisms. And following that, early rudimentary, although there were rudimentary experiments like that performed by Kushner et al., by micropuncture studies by Vernon Richards, then came the flame photometer, because measuring sodium itself was a laborious procedure until a flame photometer was introduced. Then they started identifying the receptors that are responsible, the triggers of the whole water homeostasis. So these discovery and understanding using various experimental models led us to have a better understanding. And now we have gone on to the other extreme of going into a very molecular level of understanding how the kidney maintains sodium and water homeostasis. So when we look at body fluid compartment in an adult, 2/3 is 60% approximately is fluid, and most of it is an intracellular, and 1/3 is in the extracellular, which consists of interstitial fluid, and the plasma, that is the circulating volume. But it's not always constant like this. In fact, there's a significant change in the total body water as well as the partition between the ECF and the ECF when the child is born to as the child grows. As you can see here, there's a lot of total body water that is present. And finally, as we know, they lose a lot of extracellular fluid that brings it to near adult level. And at the same time, as you notice, the partition between the ECF and ICF is almost equal in neonatal period. And that subsequently becomes 2/3 and 1/3 as the child grows. And what we need to remember is that the water freely across the cell membranes in accordance to the prevailing osmotic forces on the either side of the membrane. The solute and water ratios in the intracellular and the ECF are almost equal. The solute composition of, however, even though the what is called the tonicity or the solute water ratios are equal, the solute compositions of the ICF and ECF are very different. And although they are different, the electroneutrality is maintained chiefly by the anions of phosphate and other organic molecules in the intracellular, and by chloride and bicarbonate in the extracellular fluid. And this composition is maintained quite constant by the pump leak mechanisms consisting of the sodium-potassium ATPase, which operates in concert with the sodium and potassium conductance pathway. As you can see, the most predominant cation or the ion is the sodium in the ECF, and we all know that the predominant cation or the ion in intracellular is potassium. So, as I mentioned, the volume in respective compartments are maintained, are chiefly the responsibility of the solutes residing in these two compartments. But it is the sodium and its anions that make up the most of the solute particles, and sodium reflects the body fluid tonicity. And this we could calculate, and it is just not the sodium that is present. Sometimes and glucose and urea also contributes to this tonicity, especially in situations of hyperglycemia and renal failure. So in effect, we can consider serum plasma or a plasma sodium as a surrogate as a marker of plasma osmolality. And as you can see here, a change in the osmolality by either decrease in the extracellular fluid or increase in the solute concentration can change the tonicity. If there is a tonicity is increased, then there is water drawn out from the cells into the extracellular fluid. Following that, there is an attempt to restore the balance, and this is chiefly done through the sodium hydrogen and the sodium potassium chloride channels. Similarly, when the tonicity goes down, there is entry of fluid into the cells that expands these cells, and this is particularly dangerous in the brain because it is enclosed in a rigid skull, and hence, although all these abnormalities, the maximum effect is seen on the brain. And what we need to realize from this cartoon is that the maintenance of the extracellular fluid, the arterial blood pressure, and the organ perfusion depends on the control of the body sodium content. So, as I said, the ECF sodium sets the ECF volume. We can measure the plasma sodium, but can we measure water, how much water we have in the body? We have rough calculations, but we cannot directly measure unless you use some radius label technique. And so it is never directly measured, and it's reflected best in the sodium concentration. And this is a modification of the Edelman equation, who brought in an equation wherein the serum sodium was in proportion to the exchangeable amount of sodium and potassium in the total body fluid. So knowledge of what determines this plasma sodium is crucial for understanding the mechanisms behind dysnatremia and how to correct and prevent the disorders. So as you can see from this equation, the serum sodium can be altered if the numerator is altered or if the denominator is altered. So whenever you have a child with dysmenorrhea, you have to first ask the question, is it because of the numerator, that is the salt changes in the sodium per se, or is it because of change in the water content of the body? And invariably, most of the times, the abnormal serum sodium concentration that you find in a child is usually because of a disorder in the denominator, that is in the water balance. So it will be helpful to think of conditions that could change the numerator or the denominator when we are thinking of dysnatremic conditions. So when we come to the homeostasis, this is a broad outline. And I must say that although the water and salt homeostasis is interlinked and tightly correlated, it is actually independent of each other. So in the homeostasis of these, there are sensors like, of what is sensed, that is the osmolarity in water and the effective circulating volume in sodium. And these are sensed by special organs like osmoreceptors or baroreceptors, and they trigger a lot of secretion of various molecules like ADH, and in case of sodium, like renin-angiotensin system, catecholamines, and natriuretic peptide. And finally, it results in a response from the kidney, either in terms of excretion or retention of water or excretion or retention of sodium. And all this, we can track it if we measure the serum sodium and urine sodium. So when we look at sodium homeostasis, as I said, our average intake in a child is approximately 100 millimoles. That is around less than 5 grams, and it varies between 2 to 5 grams based on the age. And in adult, it goes up to 300 millimoles. And most of them remains in the body water, either in the ECF or the ICF. But there is a significant proportion that is non-exchangeable that remains in the bone and other soft tissues. And of the exchangeable of sodium, most of it is available in the extracellular fluid. And the body tries to maintain the sodium within a very narrow range of 135 to 145. In practice, any deviation in the extracellular volume in relation to its capacitance is translated under the influence of various neural and hormonal factors into appropriate change in sodium secretion principally through the kidneys. The most, as you can see, to maintain the balance, whatever has been taken in needs to be excreted out, and most of it is through the kidneys, and some amount is through the form stool and sweat. But what we need to remember is that in a critically ill child, there can be other sources of sodium losses, especially if you have NG tubes or child has diarrhea. As you can see here, the gastric juice, the pancreatic juice does contain some amount of sodium, even the small bowel. And in diarrhea, if it is moderate or severe, like in cholera, you can lose a substantial amount of sodium. So what happens in the kidney? As you know, in a normal individual with a normal kidney function, the GFR is approximately 100 ml per minute. That means 144 liters of primary filtrate is formed. And this, if you consider 140 milliequivalent of sodium per liter as a normal concentration, then this filtrate contains 20,000 milliequivalent of sodium, which is equivalent to 1.2 kgs of salt. Now, if this was to pass through like that through the kidney, it means that we needed to take 1.2 kg of salt every day to maintain the sodium balance. But fortunately, we don't have to do that. Although we would have loved to do it, we don't have to do that because kidney is very efficient in reabsorbing sodium. As you can see here, most of the absorption of sodium, around 60 to 70%, takes place in the proximal convoluted tubule and proximal straight tubule. Another 25 to 30% happens in the thick ascending loop of Henle. And by the time, and if I straighten up this whole tubular structure, by the time it reaches the distal convoluted tubule, around 90% of the filtered sodium is already retrieved. In quantitative terms, sodium reabsorption, therefore, is mostly a function of the proximal nephron, that is the proximal tubule and the thick ascending loop. Nevertheless, because of the magnitude of rate of ultrafiltration, that is 10% of it enters into the distal tubule of the filtered load, is still a large amount. And what is known is that And this is very tightly regulated, as Thangavelu sir said, in the sodium reabsorption excretion in the distal tubule. And failure of this distal nephron to reabsorb sodium is generally more deleterious to sodium homeostasis than the proximal nephron malabsorption. And the fine tuning of the sodium content in the urine by the distal nephron is quite flexible. So you can have a urine sodium ranging from 10 to around 1000 milliequivalents. So as you can see, there's a large variation the kidney allows in the urinary sodium concentration. So how does sodium reabsorb? Now we have a better understanding of the molecular pathways, channels that are involved. Like in proximal tubule, it is the NAH transporter. In the thick ascending loop, it's the NKCC2 channel, and also the ROMK, which tries to maintain the positive gradient across the lumen. In the distal convoluted tubule, it's the NCC channel. And in the collecting duct, the principal cells play a critical role. As you can see, the ENAC channel, which is involved in absorption of sodium, and ROMK, which is involved in secretion of potassium. And in addition, you have the aquaporin water channel. Apart from this, the intercalated cells also play a role in secretion of protons. Very important in all these parts of the nephron is the basolateral membrane. That is the membrane that connects with the capillaries. And here, the critical channel is the sodium-potassium pump, which is a very energy-driven process. So needless to say, any disturbance in any of these channels can result in abnormalities in sodium absorption and secretion. So you have conditions of genetically inherited conditions like renal tubular acidosis, Bartter syndrome, where these channels are affected and there is failure to reabsorb the sodium as we should normally do, which results in significant amount of sodium wasting. So one of the reasons of hyponatremia in pediatric is channelopathies, that is inherited defects in any of these channels. So before I go into what factors regulate sodium reabsorption and excretion in kidney, I would like to ask two questions. In a setting of hyponatremia, what does the kidney do? Does the kidney preserve sodium? Is there an increased absorption of sodium? Is it true or false? Unfortunately, we don't have a buzzer round what we used to have regularly in-house CMEs that Mehta used to conduct. The second question is, if you have a high urine sodium, if this urine sodium concentration, typically in a renal tubulopathy, like I explained, Bartter's and renal tubular acidosis, where there is a lot of sodium wasting, the urine sodium concentration measurement can help us distinguish for the cause of hypernatremia between a renal tubulopathy and one other common condition that you see in a sick child, that is syndrome of inappropriate diuresis. So going through the physiology will help us understand whether these statements are true or false. So the regulation of filtration of sodium and reabsorption is based on two critical factors. One is called the glomerular-tubular balance, and the other one is called a reverse tubular-glomerular feedback. And they're a little confusing terms, but I'll try to explain this because this is very critical involved in maintaining sodium homeostasis. But what I need to mention here is that the kidney, unlike for water, which has osmoreceptors in the brain, kidney does not sense or detect serum sodium concentration. It responds to changes in the effective circulating volume and indirectly affecting the sodium reabsorption and concentration. So clearly, a hyponatremia or a hypernatremia does not necessarily mean that in this setting there is increased absorption of sodium or increased, or a decreased reabsorption of sodium. So how does sodium homeostasis maintain in the kidney? What is glomerular-tubular balance? It is a mechanism very intrinsic to the hemodynamic and structural properties. It has nothing to do with the channels that I have described. It is basically the hemodynamic and the structural properties of the proximal tubules. What this ensures is that the fluctuation in the GFR, and this is the efferent, and therefore the filtered solute load are matched by near proportion changes in proximal tubular absorption. In simple terms, if there is a decreased renal perfusion, there's an attempt to increase the sodium absorption. If there is an increased perfusion, or the body is trying to remove the extra water, then there is a decrease in the sodium absorption. So adapting this reabsorption to filtration has a dual function of minimizing the sodium and fluid losses when the GFR increases. It also helps in preventing the cessation of tubular flow when the GFR decreases. So why? Because we need some amount of sodium in the distal nephrons for efficient regulation of potassium and acid-base balance. So, this hemodynamic changes in relation to GFR. When the GFR decreases, there is a stimulation, there is increase in sympathetic nervous activity, there is increased stimulation of renin aldosterone, and there is a constriction of the efferent arteriole in order to maintain the GFR in glomerular tubular balance. What is a tubular glomerular feedback? This refers to the sodium delivery that is happening in the distal nephron. So you have specialized 10 to 15 cells in the distal nephron called the macula densa cells, and these cells adjacent to the tubules. And this junction is between the efferent and efferent arteriole, and it is very close to the glomerulus. So the sodium homeostasis is well served by a mechanism that senses an increase in sodium chloride delivery to the late nephron and uses this information for a counter-regulatory response. So these macular denser cells, which are situated near the transition of the thick ascending loop to the DCT, acts as a sensor for the sodium chloride concentration. So the same channel which is present in the thick ascending loop is also present in these specialized cells. And their output, whatever signal is triggered, affects the tone of the afferent glomerular arterioles, such that the fluid escaping the absorption along the proximal tubule can exert a negative control on the GFR. That is, what happens is when more than what is required of sodium is present in the distal tubule, it senses it. It knows that there is a lot of sodium leaking. So it tries to conserve that. So there is a signal mechanism, which I'll come to, that results in changes in the resistance of the afferent arteriole. So both increase and decrease in the sodium concentration in the macula densa will cause a tubulo-glomerular feedback adjustments of this efferent arteriolar resistance. While in glomerular tubular balance, it is the efferent arterial resistance that is mainly impacted. So the increase and decrease in the arterial pressure elicits parallel adjustment in the renal arterial resistance, that is mainly in the tubular glomerular, is basically in the efferent arterioles. So what are the substances that regulate these hemodynamic changes? So as I said, there is a differential regulation of the efferent and efferent arterioles. So there are vasoconstrictors that are secreted or stimulated in presence of low circulating volume, chiefly the renin-angiotensin system and the sympathetic activity. And on the other hand, to maintain the lower the resistance of the afferent arteriole, you have what are the prostaglandins and nitric oxide. So this balance between the vasodilators and vasoconstrictors are very important in maintaining the perfusion of the kidney and the glomerular filtration and the subsequent sodium absorption and excretion. And this sodium absorption and excretion also affects the water absorption and secretion. So now coming to the water, it is a little different. As I said, sodium has no sensors, but water, it's basically the hypothalamic neurohypophyseal renal axis that maintains the water balance during variations in water intake and non-renal losses of water. The regulation of water balance is governed by a high gain feedback mechanism involving the hypothalamus, the neurohypophysis, and the kidneys. So an increase in the osmolality in plasma activates the hypothalamic stretch receptors to stimulate the vasopressin secretion by the posterior pituitary gland. The resulting increase in vasopressin secretion leads to an increase in renal water absorption and a decrease in water excretion. And increase in the water absorption reduces the plasma osmolality and inhibits the further ADH secretion. So this is the high gain feedback mechanism. The osmosensing in the hypothalamus also stimulates thirst, and drinking water also helps retain plasma osmolality, maintain the plasma osmolality. And this thirst mechanism can be impaired, or can be that even if especially in infants, even if they're thirsty, they may not have access to the free water because they cannot convey the thirst. So osmoreceptors are the key to water balance, while the other receptors, volume receptors and located in the heart, and high pressure baroreceptors are the key to the sodium balance. That is, the effective circulating volume triggers these receptors and then leads to what I have just described, the glomerular-tubular balance and the tubular-glomerular feedback. So this is a cartoon of the osmoreceptors. So as I said, the ability to internally sense the osmolality is fundamental to the water homeostasis. So there are specialized neurons located in several brain areas, including organovasculum, lamina terminalis, and the supraoptic region. And these respond to the extracellular changes in the tonicity. And the channel TRPV, the calcium channel, is mainly responsible for triggering the further biochemical and other pathways. So this non-selective calcium permeable cation channels in the sensing neurons, they serve as stretch receptors, and it allows. So what happens is, when there is hyperosmolality, there is dehydration of this cell and a trigger for ADH. When there is hypoosmolality, there is entry of fluid into the cell, which stretches and inhibits ADH secretion. So these receptors are basically monitoring water balance indirectly by reacting to the changes in the tonicity of the extracellular fluid. So what happens? What are the stimulus for secretion? As you all now realize that vasopressin is the critical hormone that is involved in the water regulation. So there are a couple of triggers for this vasopressin. As you can see, the main trigger is plasma osmolality. When the plasma osmolality increases to above a physiological threshold, that is 285, some say 290 and above, there is increased secretion of peptide hormone vasopressin. In addition, there is also a stimulation of thirst. And the threshold for thirst is generally 5 millimeter above the threshold. So that is fortunate. So we don't have to keep drinking to maintain the water. So only when the plasma osmolality exceeds, goes very high, then only the thirst is stimulated. Until then, it is the vasopressin that does the job of water conservation. So apart from the sodium that can change the stimulus, there is also other osmotic substances like mannitol and glucose, which can do the same thing. In addition to osmotic stimulus, this ADH can be also stimulated by other factors, which does not necessarily change the osmolality of the fluid. For example, pain, nausea, hypoxia, drugs like antiepileptics and other chemotherapeutic agents can all stimulate ADH. And these are called inappropriately stimulated situations, because ADH is not released here because of change in osmolality, but it is through the other mechanisms. Now, it is not necessary that there is always change in osmolality. For example, if you have a child with diarrhea and dehydration, there can be an isotonic dehydration. So there is no change in osmolality. So what happens here? How does ADH get stimulated? That's the second mechanism, and that is by detecting the change in blood volume. So here, while the change of more than 1% triggers ADH, here you need at least 5 to 10% of change in the blood volume to trigger ADH. But the trigger is much more powerful as compared to osmolality. So if we assume that for 1 milliosmolar, 1% change, there is 4 picogram release of ADH. For a 10% change in blood volume, there is 40 picogram change of ADH. So there is 10 times more potent release of ADH as compared to changes in plasma osmolality. And the second thing that we have to remember is that suppose you have a dehydration and at the same time there is sodium loss, which results in hypotonicity. So technically, when there's hypotonicity, there should be inhibition of ADH. But the body, because for its survival, places the hypovolemic stimulus to ADH, will override the hypotonic inhibition in such circumstances, and volume will be conserved at the expense of tonicity. So this we need to understand, that although there's a wide, the stimulus is much later, it is more stronger in case of hypovolemia, and also the hypovolemia stimulus overrides hypotonic inhibitions in case of dehydration, which is coexisting with low sodium. So what happens when these triggers happen? So this is an experiment. So I want to ask a question. Suppose we give continuous vasopressin infusion to a healthy human or a healthy child. Will the urine become nil? So as you can see that there is an inverse relationship between urine osmolality and urine volume. So the x-axis is the urine volume, and this is the urine osmolality. So changes in the plasma AVP concentrations happens when the osmolality increases. As you can see here, the plasma AVP concentration increases, but the AVP concentration change is much larger, has a much larger effect on urine volume at lower AVP concentration than at a high plasma AVP concentration. So as you can see here, when there is no stimulus to the plasma osmolality is normal, no stimulus to AVP, you can almost, in a healthy human adult, can produce almost 1,000 ml per hour. And when the plasma osmolality is very high, it will be less than 200 ml per hour. So there is a huge capacity for the kidney to excrete large volumes of dilute urine, and also to concentrate the urine. So the osmolality can vary anywhere between 50 to 1,000 milliosmolar. But this is limited in case of neonates, as we all know, because of tubular immaturity. And this variation in osmolality allows a large amount of to exceed large amount of dilute urine, so which enables people to take large amount of water. So the critical mechanism in water homeostasis and absorption of water by ADH is maintenance of the medullary concentration gradient. So as you can see here, the medullary concentration gradient is maintained by many factors, one of which is the loop of Henle. The major function of loop of Henle is generation of and maintenance of this interstitial osmotic gradient, which increases approximately from 290 in the renal cortex to 1,200 to the tip of medulla. So as you can see, there's a vertical, creating a vertical quadrimolecular gradient. How this does is because of the unique hairpin structure, wherein the flow in the ascending limb is in the opposite direction to the descending limb, which multiplies the single effect of sodium and water reabsorption. And second thing is that the thick ascending loop is relatively impermeable to water, but permeable to the sodium absorption. So these two factors helps in the loop of Henle maintain the medullary gradient. The other factor that maintains this medullary osmotic gradient, which I have not shown in the picture, is the vasorectae, where the countercurrent multiplier function also is present in vasa rectae. So another molecule that maintains this is urea, which I will come to later. So based on the changes in the medullary concentration, the urine can be hypotonic or hypertonic. So as I said, for water to be reabsorbed, it is important to have an intact medullary with a high tonicity. Only then does the ADH work. So as you can see here, the ADH works on two forms of channel. One is the aquaporin channel, and the other one is the urea channel, both of which, as I said, urea is important also in maintaining the medullary osmotic gradient. So in presence of dehydration, there is secretion of the of AVP, which attaches to the receptor called AV2 via receptors, and that triggers a lot of cellular signals. One which is immediate, that is, it helps in transport of the aquaporin in the vesicles into the luminal membrane. The other is by increasing the protein production, which takes a little more time, which involves the CAMP pathway. So needless to say, any defect in the genes that prevents the production of aquaporin or in the deficiency in the receptor can result in what is called a nephrogenic diabetes insipidus and the associated dysnatremia. And apart from the action of ADH on the aquaporin channels, it also affects it's not there is the ENaC channel. There is also increased absorption of sodium. There is also increased absorption of urea in dehydration. And that's why you get a disproportionate high urea. You know that, we always say that why is urea high as opposed to creatinine in severe dehydration? And this is one of the mechanisms where ADH also stimulates urea entry into the medullary interstitium and thereafter into the capillaries. So while I'm talking about the regulation of water and sodium, the urine flow can be considered as of two components. Like I said, what happens when you give continuous vasopressin infusion to a healthy individual? The urine output does not go into zero. Why? Because we need some amount of water to be excreted if we are going to excrete the solute, that is all the sodium, potassium, and other solutes that we are what we're taking in food. So the urine can consist of free water clearance and a solute clearance. The solute excretion actually determines water excretion. As you can see in the graph, as the solute component, daily solute excretion changes, the amount of urine that is volume that needs to be excreted also changes. So if you have a high osmolar load, solute excretion, the amount of urine that needs to be excreted is much higher than when you take a small amount of solute. And this is typically seen in beer potomania, what is called a tea and toast diet. So what happens is, because of low solute excretion, only low amount of urine needs to be secreted. So the amount of free water clearance is low. So when you take a lot of free water, what happens? That is not excreted, and that leads to a dilutional hyponatremia. So in summary, what I want to say is that this graph emphasizes that for any given urine osmolality, it is the solute excretion that sets the ceiling of how much free water will be excreted. And this is also the principle of managing SIADH with using urea. So by increasing the solute load, you are trying to increase the urine volume that is going to be excreted. And this is also the mechanism of polyuria and hyperglycemia with mannitol. So when the solute load increases, the amount of urine that is excreted also increases. And there is a formula that is available now to calculate whether the body is excreting free water appropriately. So you know that, as I said, the urine flow consists of free water clearance and solute clearance. So how do we use this in practical, practically in a case? So as I said, I'm not going into the equation. The free water. So as I said, the urine, we know what is the urine volume that has been cleared. We can easily measure the solute clearance by measuring the sodium, potassium, and osmolality. So like in extracellular fluid, where plasma sodium determines the urine osmolality, in urine, it is the urinary sodium. So we can estimate free water clearance by combining the urine volume and also using the urinary sodium and serum sodium in this equation. So for example, if you have a 16-year-old child with a serum sodium of 130 milliequivalent, who's passing urine volume of 1800 ml per day, and spot sodium and potassium concentration are 50 and 33 milliequivalent respectively, then the free water clearance of this child is 666 ml. So if this child is going to take 1 liter of water, we know that this child is going to develop a dilutional hyponatremia. And to prevent that, you need to restrict the amount of free water to below this amount that is obtained. If we don't want to calculate this way, we can also use the solute ratios of urine and sodium. So if the urinary sodium potassium by serum sodium is more than 1, then fluid restriction will not be able to increase the sodium. Whereas if it is less than 0.5, it is indicative of a good response to fluid restriction. And by using this urine chemistry, we can titrate how much of free water the child should take when the child has hyponatremia. So how do we apply this physiology? This is a busy child, but I'll take you through it to understand few important concepts. So as I said, the critical is your extracellular or effective circulating volume. So if the effective circulating volume is decreased, either because of loss of fluid or loss of both, there is a decrease in the effective circulating volume and perfusion to the kidney. There is increased renin and angiotensin secretion, which results in increase in the aldosterone and ADH release as well, and leading to increased urinary retention, decreased urinary water loss, and also it stimulates thirst, which results in increased water intake, and the homeostasis is restored. So basically, in setting of dehydration, you will get a low urinary sodium, you will get a low urinary output with a high urinary osmolality. On the other hand, if the ECF volume is increased, like in syndrome of inappropriate diuresis, either because of gain of fluid or because of iatrogenic, where you're giving a lot of sodium-based IV fluid, there is increase in the effective circulating volume, which stretches the receptors, volume receptors in the heart, that stimulates the atrioneuropeptide release, and there is a pressure natriuresis that happens. Apart from that, there is inhibition of the aldosterone, ADH, and inhibition of the thirst, which results in the decreased water intake, increased urinary water loss, and an increased urinary sodium loss. So although there is fluid gain, which results in a dilutional hyponatremia, because of this mechanism, what you find is that there is an increased urinary sodium loss. And that is basically result of inhibition of aldosterone as well as due to the pressure natriuresis. So coming back to my question, the physiology summary can be done in two simple. One is that sodium handling in the kidney is determined by the effective circulating volume rather than plasma sodium. So if you have hyponatremia, and especially if the fact that kidney should preserve sodium is not correct, as I've shown just now, that the sodium will be excreted, in fact, in order to restore the extracellular volume back to normal. Similarly, an elevated urine sodium level does not necessarily indicate primary renal salt loss, because an increased urine sodium may be also an appropriate physiological response to a water load. And hence, it cannot distinguish between a salt-wasting renal tubulopathy and an SIADH. So how do we evaluate, last few slides, how do we evaluate sodium dysnatremia? So as I said, it's all about volume and total body water. So we need to have the weight, the blood pressure, assess dehydration, and the urine output. We also need to know, and especially in a hospitalized child, the type and volume of fluid administered, and also the other losses that happens, like especially like NG aspiration, diarrhea, and so on. And in the labs, we need the renal function, the plasma and the urine osmolality, and the urine and the plasma electrolytes, and plus other investigation that can provide a clue to the underlying cause of dysnatremia. So some few facts that we need to keep in mind is that when we're ordering this lab, we need to simultaneously order all the labs. Ideally, we need to do a 24-hour urine to know what is the actual sodium and potassium excretion. That's not practically feasible, but we need to be aware that the spot urine chemistry is very dynamic. It can be influenced by the IV fluid that we give and the diet. And what we need to know, especially in urine chemistry, is that there is no normal value, only expected values. And that I will tell through case vignettes how to interpret that. So because these are expected values, we must interpret the urinary electrolyte with the clinical condition of the child. So when you have a child with dysnatremia, hypo or hyper, we need to apply these concepts. The first question that we ask is there an abnormality of sodium or of water? We need to clinically assess, is there volume excess or volume depletion? Then we need to look at the concurrent plasma and urine osmolality and electrolyte, and then use this biochemical and clinical data that we need to integrate to arrive at the diagnosis. So this is a nutshell approach. So in case of hyponatremia, like I said, whether there is a dehydration or there is euvolemia, is it too much water where you don't get a dehydration? If there's too little salt, you will get dehydration. And then using a combination of urinary sodium and urinary osmolality, we can identify the causes. In general, most of the hyponatremias are having low plasma osmolality, except in hyperglycemia and mannitol, where there is hypertonic hyponatremia. Otherwise, generally, there is low plasma osmolality. And in generally, the plasma urine osmolality are high or equal to plasma osmolality in all conditions, except in psychogenic polydipsia, where the urine osmolality is low. On the other hand, if there is dehydration, there is generally conservation of sodium and water that results in a high urine osmolality. And the dehydration is usually because of extrarenal salt losses. But if you have a primary tubulopathy, you could still get dehydrated. But here, the urine sodium will be high and the urine osmolality will be equal to your plasma osmolality. So with other conditions like adrenal insufficiency and congenital adrenal, basically conditions associated with aldosterone insufficiency. Similarly, in hyponatremia, you can again ask the question, is it too little water or too much salt? If it is too little water, you will expect decrease in the weight, the BP stable or decreased, or normal or decreased in turgor. And generally, in this hypernatremic condition, there is hyperosmolality. And generally, when there's hyperosmolality, you will expect lot of absorption of water. So urine osmolality should be technically high. But if you find it low, that means the concentrating ability of the kidney is affected. So to help you more clearly, I'll go through last four cases. Just 4 minutes, please give me. Sodium, suppose you have a child whose sodium is 122 and the osmolality, which is true, is 257. What do you expect? There is hypotonicity. So that is, there is probably an addition of water in this condition. But how do we make out? When we look at the urine sodium, it could be because of, this condition also could be because of dehydration. How do we know? Just looking at the lab, it is not dehydration because the urine sodium is high. So generally in dehydration, there is conservation of sodium. And also what we find in this child is the urine osmolality is high. Generally, when you have hypotonicity, you should excrete more free water. So the urine osmolality should be low. But in this child, it was high. So that means there is some defect in the concentrating diluting ability of the kidney. So when you go back to the history, this child had no signs of dehydration, weight was static since admission, the blood pressure was normal, and he was actually in the neurosurgery ICU. The call came from neurosurgery ICU with his child being admitted following fall from height. So obviously there is something happening with the ADH secretion that is setting this picture. So as you can see here, interpreting the urine biochemistry needs to have a good correlation with your history and physical examination. Let's go to this child who has a serum sodium of, again, 130, which is mild hyponatremia and a low osmolality. What do you expect? Again, you expect that there should be a lot of free water excretion. So your urine osmolality should be technically low. Okay. But what you find here is that urine osmolality is again high. But unlike the other child, this child has a low urinary sodium excretion. So what does this mean? You can only interpret what this is if you see this child. As you can see here, this child has gained weight since admission. On examination, has raised JVP, hepatomegaly with pleural edema, probably a congestive cardiac failure, where there's total body water content is high, but the effective circulating volume is low. And that is why you are getting a urine sodium, which is low. So the cause of hyponatremia in this child is probably cardiac failure in nature. This is a third child where you have a low sodium and a low osmolality. Okay, again, you'll expect the urine osmolality to be low because you want to excrete the free water probably, which has been accumulating. But here you find that the urine sodium is high. The urine osmolality is almost equal, neither low nor very high. What could be the cause here? So generally, when you have when you have a high sodium, it could mean two things. One is the overall free water is very high, or the tubules that are supposed to reabsorb sodium is not working properly. So on examination, this child had bilateral palpable renal mass. So this was a child of ARPKD, where this homeostasis of renal absorption was not happening. And generally, these children have isothenuria, where there's a fixed specific gravity and also it equals the plasma osmolality. So basically, this child had hypernatremia because of increased urinary loss of sodium. The last case, here it is the other side where the sodium is very high. And commensurate with the high sodium, you are getting a high plasma osmolality. So here, what should it be? That means the osmolality results in secretion of vasopressin, and technically there should be increased absorption of water from the kidney, resulting in a high urine osmolality. But what this child had was a very low osmolality, which means that the ADH is not acting appropriately. That is, there is a defect in the concentrating ability in this child. And this child was referred for increased frequency of urination, drinking a lot of water. There is history of hospitalization in the past for dehydration. So clearly, this was a child with nephrogenic diabetes insipidus. So in summary, the kidneys regulate sodium reabsorption to maintain volume homeostasis, but not to maintain a normal sodium concentration. The water homeostasis is driven by changes in plasma tonicity, as well as changes in the effective circulating volume. We need to have a proper understanding of the physiological principles of renal salt handling, especially its connection with volume homeostasis. Dysnatremias are more likely due to disorders of water balance. A tonicity balance, like how I explained, looking at the plasma osmolality, looking at the urine osmolality and urine sodium can help us understand the reason for dysnatremia. And in fact, in all children with dysnatremia, you need to do a urine osmolality and a urinary sodium, which will give enough clue to the underlying etiology and its subsequent management. Thank you for your patient hearing.
Thank you very much, sir. Professor Anil Vasudevan. Sir, Professor Namalwar, sir, do you want to make any comments, sir? Professor BRN? Professor BRN, you want to make any comments? Anil, sir, can you stop your sharing?
Yeah.
Sir, thank you very much. It is a fine talk. Beautiful talk. It reminds me the words of Albert Einstein, because once Albert Einstein asked, he is considered an atheist. He asked, why did you not believe in God? He said, I believe in God, and not a God who is sitting in a chair and deciding who is going to get $1 million prize or who is going to die tomorrow. I see the presence of God in the dazzling rules of the universe. So many planets are revolving around in the sky and they don't collide with each other. I see the God there. Similarly, I see the God in the presence of the physiological facts which you told is fascinating, sir. Really, really interesting. I thank God for two reasons. One is, he didn't involve me in maintaining the sodium balance. I cannot do any work. I have to sit in a chair, calculate everything, do a lot of calculating work, and then fix my sodium, fix my glucose. Fortunately, he didn't give the responsibility to me. Second reason for thanking is, I didn't know anything about ENAC channel or all these DUX channels and then countercurrent hypothesis, but still my serum sodium is normal because God or nature is taking care of it. Thank you so much, sir. It's a very, very fascinating talk. Even though we can't understand fully, sodium and water balance is something like our spouses. Nobody can understand their wives. Nobody can understand their husbands. But everything going on peacefully, we rely on them, and they are essential for life. With this, I thank Professor Anil Vasudevan for his wonderful talk. I invite Professor Indira Jayakumar. The Professor BRN has come. You want to make any comments, sir? Professor Indira Jayakumar is a senior consultant in Pediatric Intensive Care Unit and Emergency Unit of Apollo Children's Hospital, Cancer Hospital, and Proton Hospital. She did a DCH from Institute Health, Chennai. DNB from Kanji Kamakodi Child Stress Hospital, Chennai. He did a fellowship in pediatric critical care from Perth, Melbourne, Australia. She is currently a senior consultant at Apollo Hospital, Chennai for the last 14 years. Started Apollo Shine Foundation and is a medical director of this. It's a non-profit initiative for the student health of Apollo. He's responsible for starting pediatric ECMO and trauma center at Apollo. She's a coordinator and teacher for emergency and critical care fellowship program. She had a lot of publications in the international as well as national journals. She's contributed many chapters in the books published from national as well as international arena. Because of her teaching ability, she was conferred a title associate professor by AHERF Imjiyar University. I've observed her in the last few decades. Any complicated topic you give to her, if there is sodium disturbances, or arterial blood gases, or pulmonary physiology, she'd make everything so simple and make it understandable even by a school student. It is so interesting and palatable. Over to Professor Indira Jayakumar on sodium disturbances. You can present your slides now. Can you share your slides?
Yeah. Is this fine? Am I audible, Dr. Thangavelu?
Yes.
Good evening, everybody. I thank Dr.
Not seeing your slide. I'm not seeing your slide.
Oh, sorry. I've not shared it.
You have to share the slide.
Yeah. I've not shared. Sorry. And one sec, sir. Is this now visible?
Yeah, you have to select.
Yeah.
Slideshow.
It's shared, no, sir?
Yeah, sharing slideshow. Keep it in the slideshow so that it is visible.
Is this fine, sir?
Fine. It's visible. Keep it in the slideshow. You have to,
Yeah. This is fine?
Yes, please. Yes, good.
Yeah. Good evening, everybody. I thank Dr. Thangavelu for the very kind words, and you have now yet again set a challenge for me the next 45 minutes. Dr. Thangavelu has been my teacher, and he's a teacher par excellence. I've always learned something, including philosophy, from him. I owe my gratitude to another teacher and guru, Dr. Namalwar, who is here. And thank you for this invite, sir. Dr. Kalaivani, thank you for the invite, and IPNA Society. Dr. Anil has elaborated the physiology of dysnatremias from a nephrology perspective. And for over the next 45 minutes, I will just, with some case scenarios, share the challenges, the investigations, and the treatment of sodium disorders from an emergency and intensive care perspective. I hope I'm audible, Dr. Thangavelu.
Yes, audible.
Yeah. So sodium and water, as all the speakers have already emphasized, they go hand in hand. And as Dr. Anil has also emphasized, it looks like that the water is the dominant one and not the sodium. So the sodium follows the water. And I'm sure you know who is the dominant among them from the figure, the male or the female. Well, so what is osmolarity? Osmolarity, we know this is the formula 2 into sodium plus glucose 18. So you have the sodium, which is a major contributor for osmolarity in our serum, and glucose and urea. But what is effective osmolarity or tonicity? So those are the solutes which actually drag water. And these, so sodium and glucose contribute to effective osmolarity or tonicity, not urea, because it crosses across the cell membranes and does not really contribute to your tonicity. So when we talk about shifts of water from inside to outside the cells, it is mainly because of sodium or glucose. Now, ADH, as has been elaborated before, the physiological stimulus for ADH, that is appropriate ADH stimulus, is hypovolemia and hyperosmolarity. So So whenever the kidney senses hypovolemia or low fluid, ECF volume, or increased solutes, you'll have appropriate areate secretion. And I have to give due credit to Professor Edelman, who actually configured this equation, which helps us and treat all the dysnatremias. So what is this equation? This is the Edelman equation, which says that your plasma sodium is dependent on the numerator, which is the exchangeable sodium and potassium, and the denominator, which is the total body water. And sodium disorders are created if you have low or high total body water, or low and high, that is loss or gain of sodium. Now, if you have hypernatremia, goes without saying, it is because predominantly due to low total body water, and can also be due to a high exchangeable sodium. You can see that even potassium contributes to your plasma sodium level. Hyponatremia is because of high total body water, so water gain, or your low sodium. Now, so where is the sodium in the body? So it depends on your intake as well as what goes out in the urine. And there is 30% which is non-exchangeable, that is in the bones and cartilage. So about 70% of sodium is exchangeable compartment. So just to summarize, and this is so very important, this actually sums up everything that happens to the brain when you have dysnatremias. So whenever there's a rapid increase in plasma sodium concentration, something that makes the sodium go very high, be it rapid correction of chronic hyponatremia or rapid onset of acute hyponatremia, it can create tears of the bridging vessels and osmotic demyelination. On the other hand, if there is a rapid decrease in plasma sodium concentration, then you have cerebral edema. So isotonic fluids do not alter the plasma sodium. Why? Because they are predominantly in the ECF, so interstitial and intravascular. So we give normal saline to all our patients, but we don't cause hypernatremia. So that's why whenever we want to replenish the ECF volume, we always give isotonic fluids. And if we want to expand the total body water to lower the plasma sodium in hypernatremic situations, we always give hypertonic fluids, because hypertonic fluids, as seen in this figure, distribute equally between the intracellular as well as in the extracellular compartment. So now let's discuss hyponatremia. So what is hyponatremia? Hyponatremia is when the serum sodium drops below 135. And it's a very common electrolyte imbalance, which occurs in 22% of hospitalized patients. And what does it do? It causes cells to swell up. So water is pulled into the cells, and that causes cerebral edema. So just an approach to hyponatremia, first look at the serum osmolality. I told you the osmolality contributor is 2 into sodium. But there are other factors that can also contribute to osmolality. Number one, very common, is your hypertonic hyponatremia. So where you have a low sodium, but you also have other things that are increasing your osmolality, despite the low which is not due to the low sodium, which creates a low sodium. So that is hyperglycemia as well as mannitol. So why do you have a low sodium in these hypertonic situations? Is because water is pulled out because of these hyperosmolar substances. Water is pulled out from the cells. Now the other situations is isotonic hyponatremia. So this is not very common now because it was a lab error when we used flame photometry, but now we use ion selective electrode methods for measuring serum sodium. And so the high proteins and the high lipids do not really confound our serum sodium levels. So now let's say we have ruled out the hyperosmolar situations due to mannitol as well as high glucose. We know when we have high glucose, we should use the correction factor of 1.6. So this is how when you have a high glucose, there's water that's pulled out from inside the cells, and that will dilute your serum sodium, and you use a correction factor. And this is why you have hyponatremia when you have a hyperosmolar state. Pseudo-hypernatremia is not very common now with new lab methods. So now, after ruling out these hyperosmolar situations, what do you look for in a patient with low sodium? That is your true hypotonic hyponatremia. So you look at your volume status. So is it hypovolemic, which is very common? So what are the hypovolemic causes of low sodium? Then you look whether there is loss. So there's something causing a loss of fluid, which is dropping your sodium. Check whether it's renal loss or extra-renal loss. So renal losses can be your diuretics, renal tubular acidosis, cerebral salt wasting, etc. Even more common extra-renal losses, your diarrhea, burns, EBD, your ventricular drainages, other drains, etc. Now coming to euvolemic. So euvolemic hyponatremia. So it is, the commonest is SIADH. In children, we do not see psychogenic polydipsia. And hypovolemic is your nephrotic syndrome, cirrhosis, and failure, congestive heart failure. So as I've already told, appropriate ADH is due to hypovolemia and hyperosmolality. It can also occur in patients with decreased effective circulating volume, like in patients with your cirrhosis or congestive heart failure, though they look hyper. So there can be a component of appropriate ADH and inappropriate ADH or SIADH. Now, there are a host of conditions that cause SIADH. You have neoplastic conditions, pulmonary, osteopressure ventilation, CNS disorders, very, very common, and drugs. So a lot of drugs that we use cause SIADH. And I see it in my cancer ICU. So due to Vinca alkaloids, very, very stubborn SIADH, cisplatinum, cyclophosphamide, antibiotics, and of course your anticonvulsants. Also, as Dr. Anil had mentioned, even pain, nausea, post-op stress, all these can cause inappropriate ADH. So every hospitalized child is at risk for SIADH. And we are now giving isotonic fluids as maintenance to all our patients because of this risk. We were giving, based on the Holiday-Segar formula, which is actually for calories, we were giving fluids. So that's a lot of fluids for patients who are prone for fluid retention and SIADH, and we were creating in-hospital drowning. So this is an article in 2006. So initially, we were using Isolite P in all our intensive care units, but no longer. It's only isotonic or near isotonic, now balanced fluids, which are used even as maintenance in all our critically ill patients, because there is the risk of hyponatremia is about 17 times more if you use hypotonic fluids or like Isolite P or half GNS in our critically ill patients. So how do you diagnose SIADH? As Dr. Anil had mentioned, this is a true hypotonic hyponatremia, but the patient is euvolemic. And though the plasma sodium is low, though the plasma osmolality is low, the urine osmolality is high and the urine sodium is also high. You also have to rule out normal adrenal, renal, and thyroid functions and cortisol before labeling a patient as SIADH. So it's just coming back to the Edelman equation. So what causes hyponatremia? So if you look sodium, let's look at the sodium, the numerator. So in hypovolemic hyponatremia, it is decreased. Euvolemic hyponatremia, the sodium is actually normal, but it's diluted, that is SIADH. There's a lot of water dilution. In hypovolemic hyponatremia, like your congestive heart failure, nephrotic syndrome, there is sodium retention, even though there is hyponatremia. So potassium, it is decreased in majority of hypovolemic and hypovolemic hyponatremia. In SIADH, it is normal. Now, with relation to total body water is decreased or could be normal in hypovolemic hyponatremia. And in SIADH, it is increased, as also in hypervolemic hyponatremia. So you can see the balance between the numerator and the denominator, that is your sodium and your total body water, which is creating this low plasma sodium in these different conditions. Now look at just eyeballing, look at the fluid shifts in hyponatremia. This is your normal ECF and ICF. You can see in SIADH, even though your sodium is low, it's all expanded, right? Now this is another with high glucose. So your osmotic cause for low sodium, you can see there's a shift from the intracellular space to the ECF because of your high glucose molecules. Now, diarrhea is one situation where there is significant ECF loss as opposed to your intracellular. And that's why in hyponatremic dehydration due to diarrhea, you have all your sunken eyes and your skin turgor is lost because you have significant ECF fluid loss. Now, in nephrotic syndrome and CCF, there is expansion of your fluid spaces despite hyponatremia. So what are the questions to ask when you have dysnatremias? First, what is the volume status? What is the urine output? Is it increased or decreased? Is the volume loss renal or extra-renal? Is there some other losses or could be both? Is the low sodium symptomatic or asymptomatic? And for how long? So anything more than 48 hours, we take it as chronic because you have your idiogenic osmoles coming into play. And then, of course, do your labs, serum sodium, potassium. So these are the basic labs that you would do for a patient who has low sodium. Then finally, what is the cause of the hyponatremia? So what's the background and how would you treat this patient? So as has already been stated before, if look at this same approach, so your euvolemic and hypovolemic hyponatremia, this urine osmolality is high in almost all, except of course, your primary polydipsia, which is very rare in children, or potomania. Your urine sodium is low if there are extra-renal losses, as well as when there is low effective circulating volume in congestive heart failure, etc. Otherwise, in other situations, your SIADH, in renal salt wasting, etc., your urine sodium is high. So symptoms of hyponatremia, the severity will depend upon the rapidity, how fast it is developed, and the degree of reduction in the sodium levels. So what is mild? Anything less than 135. Less than 130 is moderate, and less than 125 is very severe, and that you can have seizures because of cerebral edema. Also, the duration of hyponatremia, anything more than 48 hours becomes chronic. So clear, your symptoms will depend on the degree, how low is your serum sodium, how rapidly it has gone down, and your number. So your adaptive capacity is very low when it's happened very fast, and the number is also very low. Then your CNS adaptive capacity is very low, and then you can have significant coma and seizures. And why does this? So what is the adaptation? Our body does have a lot of adaptive buffers, and these are the osmolytes or organic solutes, which are your amino acids, myo-inositol, etc. So what happens when your serum sodium is low in the ECF? You have idiogenic osmoles inside your cells. So what do? They come outside. They come to the ECF to balance that low osmolarity caused by the low sodium, right? So you have low sodium. Initially, there's water getting into the cells because of your osmoles inside. But over 48 hours, these idiogenic osmoles to balance the low sodium will come out. But if you rapidly correct the sodium from low to high, when you have your idiogenic osmoles still outside, it will drag water, tear your bridging vessels, and cause a lot of hemorrhages, as well as intracerebral hemorrhages, as well as pontine demyelination if you rapidly correct your low sodium. So this is just another schematic representation. So initially, hyponatremia causes cerebral edema. After 48 hours, you have organic, your idiogenic osmoles coming out into your ECF from your brain. So they come out of your brain cells. If you rapidly increase your serum sodium, then you have idiogenic osmoles also outside your brain, as well as your osmoles outside your brain, and then that will cause your osmotic demyelination. Because your osmolarity outside in the ECF is much higher than inside your cells. So this is your representation, idiogenic osmoles coming in chronic and rapid correction of your sodium. You bring up your sodium, you still have idiogenic osmoles, you'll have myelinosis. So the rule, this is a very important rule. So anything, when you're unsure of the cause as well as the duration, it's better to correct it slowly and steadily. So rule of 6 and 6 hours for severe symptoms, and 6 a day makes sense for safety. So it's safer to always target a change of serum sodium, be it for hyponatremia or hypernatremia, just a change of about 6, because we always tend to overcorrect. So if you target 6, you'll end up with 8 or 10. If you target 12, you may overshoot. So it's safe to have only target a correction of 6, because all you want now is the patient to become asymptomatic. You're not just targeting normal numbers. And what does it cause when you rapidly correct hyponatremia and increase the serum sodium? You will cause cerebral pontine myelinosis. So basically, it's like a locked-in syndrome where the patient is quadriplegic, dysarthric, dysphagic. And remember, it can manifest a few days later. MRI will pick it up. So you can have a lot of dysarthria. And believe me, I have seen 2 patients like this. So you have to be very, very careful when you correct hyponatremia. So hyponatremia, as long as they are not at risk for cerebral edema, they are not having active seizures, do not chase the number and try to normalize it. So what do you do if your serum sodium has suddenly shot up? You try to re-induce hyponatremia, and actually you can help prevent or mitigate the osmotic demyelination syndrome. Osmotic demyelination syndrome is a higher risk in patients who have also hypokalemic, who have malnutrition, or who have very low serum sodium concentration for a long time. In such patients, please do not try to normalize the number. Even 110, if you have a serum sodium of 105, even 110 for 110 or 112 for 2 days will be fine. The patient will not die of the low sodium because he's adapted to that low sodium. On the other hand, if you bring it up to even 125, 130, he may have demyelination. And this is what I realized when we treat our patients with low sodium, that lot of our antibiotics also, apart from our IV fluids, are antibiotics and the other drugs, antifungals, have a lot of sodium. So they can actually cause overshoot of your serum sodium. Look at the fosfomycin is one drug. Now look at voriconazole. It has 1.1 grams. And then your ciprofloxacin, etc. So that's something that you have to bear in mind when you're giving these drugs and you're correcting hyponatremia. So you have to account for the sodium in the other, in the medicines also. So this is how do you treat hyponatremia? Coming back to your Edelman equation, remember you're correcting potassium also will improve your serum sodium. And the basic principle, rule number 1, your infusate sodium. So what you're giving, if you have urinary loss of sodium, your infusate sodium should be higher than your urinary losses. So this is a patient with watery diarrhea, sodium 119. So what's your choice of fluid? He's reasonably alert. So what's your choice of fluid? I know I can't get answers, but even though it's alarming, it's 119, or even if he's drowsy, you do not have to give 3% saline. You can still give normal saline. Just remember, look at this, 10 mils, a patient who is dehydrated, 10 mils per kilo of normal saline, the sodium content is similar to 3 ml per kilo of 3% saline. So it's same, 15 milliequivalents for a 10 kilo child, it's about 15 milliequivalents. So if you give 10 ml per kilo of normal saline, it's equal to your 3% saline bolus of 3 ml per kilo. And also once you hydrate the patient, your ADH stimulus is reversed. Your urine will no longer be concentrated. He will pass a lot more urine, and that itself will lower he'll pass more urine, as well as and his hydration will improve. So please do not give 3% saline in hypovolemic hyponatremia. So just to summarize, if a patient is hypovolemic and needs volume, just correct it with normal saline. Hydration itself will remove the stimulus for ADH. And once urine output improves, the osmolality of urine will also reduce, and he will stop losing sodium. More water will be lost. His serum sodium will also rise. But do keep monitoring your serum sodium. If despite correction of your hydration with your normal saline boluses, he's still symptomatic, still continues to be drowsy, sodium is still low, then you may need 3% saline. not in the initial phase. The other thing is, even for SIADH, once the stimulus for any appropriate or inappropriate ADH is gone, then your urine output will improve and there can be a dramatic increase in serum sodium, which can overshoot. So that's something you have to keep monitoring your serum sodium for. Now, this is the Adrog-Madias equation, and this is actually very, very useful when you're correcting your serum sodium. Look at your infusate sodium plus potassium minus the serum sodium and total body water plus 1. So let's say you have, what's your infusate sodium for correcting hyponatremia? This is normal saline with 154. You added potassium, which is 20. Let's say your serum sodium for this 10 kilo child is about 110. And this is your total body water for this 10 kilos, so 0.6 time. And this is the amount, this is the change in serum sodium that will happen when you give a liter of normal saline. So your sodium to start it is 110. It will improve to 119 if I give 1 liter of normal saline to this patient, right? And if we want targeting only 6 to 8 change, not 9, then you give a little less. Don't give 1 liter of normal saline. You can give a little lower amount of fluid and of course replace ongoing loss. So this equation is very useful because it actually tells you 1 liter of what type of fluid you give, the type of fluid you give, what change it will bring to your serum sodium. And so you know how exactly to titrate your fluids. Remember, equations are just a guide and you can either under or over treat. The other formula for correcting hypernatremia is which you all know, is 0.6 into weight into desired sodium minus actual sodium. Even here, I have taken only 116. So if your serum sodium is 110, I have only taken desired sodium is 116 because you don't want to overcorrect. So let's say you can use even normal saline as maintenance if it's a diarrhea patient. And if you're giving 3% saline, remember your 3% saline, 1 ml of 3% is equal to 0.5 milliequivalents of serum sodium. So if I'm giving a bolus of 3% saline and I'm giving an infusion of 0.5 mils per kilo for the next 23 hours, then this is your sodium content in that 3% saline. So it's something that you have to factor in, which we actually do not calculate when treat these patients, but you have to factor in what is the amount of sodium going in the medicines, what is the amount of sodium in the normal saline, and also in your 3% saline. And depending on the cause, you give the amount of fluid as well as the sodium. Now this is case 2. So that was for diarrhea. Now this is a patient who has meningitis, reduced urine output, serum sodium is 125, and osmolality of the serum is low, urine osmolality is very high, urine sodium is also high. So here you have a patient with CNS problems, high urine osmolality, high urine sodium, despite a low serum osmolality. The sodium dropped further. So what we did, we fluid restricted, like SIADH, we know we have to fluid restrict, and we have to give normal saline as the maintenance fluid. Why do we fluid restrict? Because there's already water retention in patients with SIADH. And the sodium dropped further, despite it dropped to 117, despite giving fluid restriction and normal saline. And why did it happen? Because of something called desalination. And what is desalination? So desalination is a concept in patients with SIADH who actually excrete a lot of stubbornly have a high concentrating urinary issue, and they will, despite the low serum sodium, they will have continue to excrete that high urinary sodium because of tubular expansion, and ADH absorbs all the water. It prevents diuresis, it absorbs water from your collecting ducts, collecting tubules. So this is a patient post-op. So what happens, because of SIADH, he's passing hypertonic urine, you are giving normal saline, and because his urine is concentrated and it has a very high fixed concentrating ability, all the sodium from the normal saline gets excreted into the urine, and what remains is water, which further dilutes whatever serum sodium that you have and drops it. So this is called the desalination, which occurs in SIADH because of the high fixed urine concentrating ability, which washes out all the sodium that you give. So 1 liter of isotonic saline, this is the sodium. And what is osmolarity of isotonic saline? Is 308. 3% saline, This is the sodium content. And what is the osmolarity? 1026. Now, what is the rule number 4? Your infused fluid must have a higher osmolarity than the urine. And if your urine concentrating ability is fixed in SIADH to a very high number, let's say 600 milliosmoles, Dr. Anil's patient, it had 680 milliosmoles. Normal saline has an osmolarity of only of 300. So what happens? Because the urine in SIADH as a fixed concentrating, is as fixed at one particular number, all the sodium from normal saline will be excreted, leaving water in the body that will further drop the serum sodium. And that's why normal saline can actually worsen the hyponatremia in patients with stubborn refractory SIADH. So what do you do in such conditions? You give 3% saline. And how does 3% saline help? Because it has a higher osmolarity than the urine. So 1 ml per kilo of 3% saline will raise the sodium by 1%. And raise in sodium, you don't want to normalize the number. You just raise it by few milliequivalents and need not raise to 125, even if the current sodium is 110, and not more than 6 to 8 milliequivalents per day. So this was already alluded to before, the urine plasma electrolyte. So this gives a guide to how stubborn your hyponatremia will be to your fluid restriction. If you do, it is very easy to calculate. If your ratio is less than 0.5, the urine has electrolyte-free water. That means that the patient is also losing some water, which is fine. So you don't need to restrict, because even if you give a lot of water, he will pass all that water in the urine and he's not going to drop the serum sodium further. On the other hand, if in patients with hyponatremia, this ratio is high, that means the urine has no electrolyte-free water. He's keeping all the water in the body. Then this hyponatremia will be more stubborn to correct. Example in SIADH. And that's when you will need 3% saline or even furosemide to increase the electrolyte-free water in the urine. And how does it happen? So this is just the same thing, urine by plasma electrolyte ratio. If it is less than 0.5, you can actually liberalize the intake. On the other hand, if the urine by plasma ratio is high, then you will have to really be tight and you will have to resort to other measures like 3% saline and furosemide. Now, furosemide role in hypernatremia. In patients with hypervolemic hyponatremia, it removes the excess water in the body. In patients with low effective circulating volume, you have to check albumin and be careful before you give your furosemide. You don't want to worsen that hypovolemic state further. Now, euvolemic situations, euvolemic hyponatremia, like SIADH, what does furosemide do? So the nephrologist always use 3% saline and furosemide in patients with stubborn SIADH. So what does it do? So it abolishes the medullary concentrating ability. So that stubborn, fixed, concentrated urine in SIADH, it abolishes that and it lowers it. So even with 3% saline or with normal saline, your serum sodium will improve. So this is your loop diuretic. So what do? They lower the concentration of in the medullary interstitium and thereby decreasing your water reabsorption. So you have more water loss. Thiazides actually lose more of the sodium. So they are very useful in hypernatremia when you have excess salt in the body. So treatment of hyponatremia in a nutshell, when you have hypovolemic hyponatremia, you give normal saline only. You don't need to give 3% saline because the amount of sodium in normal saline for that volume itself will be equal to your 3%. 3% saline if still symptomatic, and that is after your hydration correction. Euvolemic hyponatremia, you restrict your fluid, and if it's still stubborn, you will have to resort to 3% saline and furosemide because you need the infusate sodium should be much higher than what sodium the osmolarity of the urine. And furosemide will abolish the medullary concentrating ability in SIADH. So it will cause more water loss also. Now, hypovolemic state, you just give fluid restriction and diuretics. Maintenance fluid, even hypovolemic hyponatremia is isotonic. Very rarely you will need 3% saline because they already have a lot of salt retention. Now, Vaptans, I'm not going to talk a lot about it. It's useful in euvolemic and hypovolemic hyponatremia, but sometimes you can overshoot. Advantage of Vaptans is you can actually liberalize the oral fluids. So it's useful in very stubborn SIADH. Now, this is a patient with polyuria, polydipsia with low sodium. She's hyponatremic. Glucose is 780. So what is the cause? Here it's a factitious hyponatremia. So you have to use the correction factor of 1.6 for every 100, above 100 of glucose. Now, this is a patient who has got dyspnea, elevated JVP, massive ascites, edema, serum sodium is low, urine osmolality is high, and urine sodium is low because of low effective circulating volume. So what is the volume status? He's hypovolemic. Cause of hyponatremia is this hypervolemic hyponatremia. You have to restrict and give diuresis. So isotonic fluids only. You may not have to give 3% saline. Now, this is another boy with tuberculous meningitis, seizures, and low sodium, but he's polyuric. He is not oliguria like SIADH, and he's not euvolemic like SIADH. He's dehydrated and having a very low sodium. There's no history of drugs intakes like mannitol or Lasix. So what is the cause of his low sodium? Possibly you should entertain cerebral salt wasting. So what is diabetes insipidus, SIADH, and cerebral salt wasting? These are all sodium disorders. So in diabetes insipidus, your urine serum sodium is high. On the other hand, in SIADH and cerebral salt wasting, your serum sodium is low. Diabetes insipidus is polyuric. SIADH is urine output is less, and cerebral salt wasting. So there is natriuresis as well as diuresis. So you'll have a dehydrated patients in diabetes insipidus and cerebral salt wasting, whereas the hydration looks normal in SIADH. But diabetes insipidus is a hypernatremic situation. So that actually is ruled out when you have a hyponatremic situation. Now you have a nephrotic syndrome, presence to the emergency, in shock with a low sodium. Patient has been on prednisolone on steroids. What would you think of? You should think of adrenal insufficiency, and this is due to chronic adrenal suppression in patients who have been on steroids. And so if you have a low glucose, low sodium, high potassium in a shocky patient who has been on steroids, please give your shock dose of steroids. You don't have to wait for confirmatory labs and cortisol. Just give your hydrocortisone. And in pediatric septic shock, it's about 4 milligrams per kilo per day. So this is the shock dose. And you have your replacement dose and your stress dose. So patients who have been on steroids are at risk when they are undergoing a medical or a surgical stress. So you have to give the stress dose of steroids. So this is just a spectrum of all the disorders that cause low sodium in the emergency or intensive care department. And now I'll just move on to hypernatremia. So the principles are always the same. So what is hypernatremia? Serum sodium more than 145. And here, these patients are irritable. So you don't have a cerebral edema, you don't have drowsiness, but they're more irritable. You can have anxious cry, and only in very late situations or very severe states that you will have seizures. These patients have a dovey skin. They don't look profoundly dehydrated, though they could be very have a lot of water loss. And they're at risk for hypocalcemia, hyperglycemia, cerebral hemorrhage, because there's tearing of your bridging veins, and also venous thrombosis. So if you eyeball your fluid shifts in hypernatremia as opposed to hyponatremia, look at this. You have much more water loss from all your compartments, right? And there is shift from your intracellular to your extracellular. And that's why you have your dovey skin. They don't look so dehydrated because the loss is actually much more in your intracellular fluid. Your total body water is also low. So this is your diabetes insipidus, osmotic diuresis. So there's a lot of intracellular fluid shrinkage. And of course, very rarely it can also be due to your high sodium can be due to excess bicarbonate, excess 3% saline, improperly diluted feeds in infants, concentrated ORS, and that can also contribute to your excess salt. So clinical manifestations of hypernatremia. So what happens when you have high sodium, which is in the ECF, it will cause shrinkage of your brain. There's rupture of cerebral veins and hemorrhages. So mild is up to 150, anything 150 to 170 is moderate, and more than 170 is severe. And you can have even spasticity, hyperreflexia, seizures, and death. So, and this is something else that I realized. It not only affects the brain, hypernatremia, there's high predictor of mortality. And look at this mortality of 19% versus 8% in hospitalized patients. So ICU acquired hypernatremia. And it also causes impaired gluconeogenesis, cramps, rhabdomyolysis, decreased left ventricular contractility, hyperventilation, apart from your cerebral hemorrhage. So approach and causes of hypernatremia. First, look at your ECF. Is it because of salt excess that you have hypernatremia? Or is your ECF low? That means you're dehydrated. And is it hypertonic fluid deficit? That means you're not only losing water, you're losing a bit of sodium also. So that sodium loss could be renal or extra-renal. So when you have this water and a bit of salt loss, it can occur in burns. Burns patients have very refractory hypernatremic dehydration because of it's losses that you cannot actually estimate. Then diuretics, osmotic diuresis. Or is it pure water deficit? In all these, you can see. So here you have nephrogenic DI, where you have very low serum of a urine osmolality, right? Or extra-renal. This is not very common in children. So how do you know how much water, whether the kidney is losing the water, or is there some other, or is this excess salt, or there is some other loss from somewhere else? So this is the electrolyte-free water clearance that Dr. Anil had already alluded to. So if you look at the volume, it's very hard to calculate 24 hours volumes. Maybe you can look for 6 hours volume and just look at the urine and plasma, your osmolalities, right? If it's negative, that means the kidney is retaining the free water. So it's extra-renal. So the patient is not losing water from the urine, maybe from somewhere else, or there is excess salt. Now, if it's positive, that if this value is positive, that means the kidney is excreting a lot of free water. So it's renal water loss. And then you have to find out the cause. So this is once again your approach based on your sodium gain and water loss, your Edelman, and you have renal water loss due to osmotic diuresis, loop diuretics, diabetes insipidus, insensible water loss which cause hypernatremia. You can have even 3.5 mils per kilo per day of insensible water loss from your skin for every degree rise above 37 or rise in temperature. Then your diarrhea, other fluid losses, your drains, your chest tube, nasogastric suction. So these are some things that you are actually, and more than one cause could occur in a patient, and that's something that you have to keep in mind. So how do you differentiate between hypertonic dehydration and diabetes insipidus? As I've told you, in both there will be dehydration, but in diabetes insipidus, you're losing tap water. So the urine osmolality will be very, very low, whereas it will be very concentrated if you have a patient with diarrhea dehydration, hypernatremia due to diarrhea dehydration. So once again, even in hypernatremia, you have adaptation, so your organic osmolytes. So what happens here in hypernatremia? So look at this. This is your brain, right? So when you have high sodium in your ECF, there's a lot of fluid that is moved out, right? So you'll have a lot of hemorrhages when a patient comes with severe hypernatremia. Then idiogenic osmoles occur to inside the brain, inside the cells, to balance that high sodium in the ECF, right? But if you rapidly lower the serum sodium in your ECF, you still will have your idiogenic osmoles inside the cells, and they can cause water that you have given to drop the serum sodium in the ECF. All that water will get into the cells, it'll drop it, and it will cause cerebral edema. So this is what happens. High sodium can cause cerebral shrinkage and bleed. Idiogenic osmoles come into play, right, to inside the cells to balance this high osmolarity in the ECF. If you drop your high serum sodium too rapidly, there's still idiogenic osmoles inside the cells, and water that you have given to correct the sodium will gush into the cells, and you'll have cerebral edema. So cerebral edema occurs during rapid correction of hypernatremia, and demyelination occurs in rapid correction of hyponatremia. So the key is to correct it slowly. The rule of 6 still holds good, but 6 to 8. So you have to consider any dysnatremia condition as chronic, that is more than 48 hours, and avoid rapid changes. So free water deficit. This formula is useful when you have pure water loss, like in diabetes insipidus. So 4 mils per kilo of desired change in plasma sodium. Now, in this formula, I've taken desired change as 6 to 8. So you know, in a day, if I give this amount of free water fluid, then it will lower the plasma sodium by this amount, by 6 milliequivalents. And what type of fluid will you give? You're losing water. So your sodium, the fluid that you're giving should also have very low sodium content. So if it's just free water deficit in diabetes insipidus, you will give either D5, isolate P, or you would give 0.5 GNS if your sodium is dropped too rapidly. Watch for hyperglycemia when you're giving dextrose containing fluids. Now, if it's not a pure water deficit causing the hypernatremia, then if it's also sodium loss, then you can use this formula, total body water, current sodium -1. I've put the denominator as denominator as 145. You can even use 140. But remember, you do not want this much change. So you have to give this is the total fluid deficit that you are calculating through this formula. But you have to give only the fluid in a day that you want a change to occur. So I'll just explain with this equation. This is your androgmadias. This is the third formula, which actually takes into account your infusate sodium, your total body water. So this is your infusate sodium of this. Let's say your serum sodium is 165 and your infusate sodium is half normal, so 77. So this is a patient with hypernatremia of 165. You are giving half normal saline of 77. And if you calculate, 1 liter of half normal saline will drop your serum sodium by about 10 milliequivalents. So if you want to drop it only by 6 to 8 milliequivalents per day, then you can just give that amount. You may give 900 ml or 800 ml in 24 hours. You have to always give little extra fluids for ongoing loss like polyuria or diarrhea. So this is a very, very useful formula both for hypo and hypernatremia. Discussing this patient. This is a child with diarrhea. Skin feels like Pillsbury Dove, so which itself shows that this is hypernatremic dehydration. Your sodium is high, urine osmolarity is high, urine sodium 30 in a diarrhea dehydration patient. Now, in this kind of scenario, in hypotonic, in patients where you have sodium and water loss causing hypernatremia, it's not enough to only calculate the free water deficit. You have to look at the total fluid deficit because there is loss of sodium also. So let's say this patient has 10% dehydration because of diarrhea. So 10% of dehydration for a 10 kilo child is 1000 mils. Free water deficit of that is you can use 4 mils per kilo formula, or you can use your 0.6. So you have about 0.6 into this is 0.6 into 10. This is your total body water for a 10 kilo. Your serum sodium by expected -1. And this is over 48 hours because you don't want so much change in serum sodium. This is your remaining loss. So this is your free water deficit. Your total fluid deficit is 1000 mils. So if free water deficit is this much, then your remaining deficit is this. You give it over 48 hours. If tolerating enteral, this free water deficit can be given as water or NG or any feeds, which have actually low sodium. So to summarize, treatment of hypernatremia, free water for stable patients, that is the best in the oral route. Normal saline or ringer lactate, that is sodium containing fluid, should be used only if they are in severe shock in patients with hypernatremia or they are hypotensive, because you don't want to cause more sodium overload. The advantage of giving fluids with a little higher sodium is you can give more fluid. You can correct the hydration much more, and your serum sodium will not drop so much. So if the patient is profoundly dehydrated and your serum sodium is very high, you can start actually with a little more isotonic fluid so that you can correct the dehydration without too much drop in your serum sodium. Now, half normal saline is used more for the maintenance fluid. So maintenance fluid can be half DNS, or if it's a patient with diabetes insipidus, you would want to give even lower, either free water or dextrose, 5% dextrose, etc. So this is just algorithm. treatment of hypernatremia, assess volume status, look for hypovolemia. So these are your typical diarrhea dehydration patient. Remember here, you correct your volume deficit as well as your free water deficit. So here, administer isotonic saline, and then you correct your water deficit with 0.45 saline, 5% dextrose, or oral water. If it's just euvolemic hypernatremia, then you correct only your free water deficit with hypotonic fluids. If it's hypervolemic, this excess salt that's also been administered, then you remove the salt with either thiazide diuretics or furosemide, and of course also correct your water deficit. If the sodium decreases too rapidly, then what do? You don't want that to happen. First thing is, I said, sodium always follows water. So reduce your rate of IV fluid. Probably you're overestimated the amount of fluid that is required. So you reduce the rate of IV fluids. The next resort only should be to increase the sodium concentration. So first you should always reduce the IV fluid rate. If the sodium decreases too slowly, you can increase the rate of IV fluid, and if need be, reduce the sodium concentration if it was isotonic. If seizures occur during treatment, if the sodium is dropped too rapidly, then you may have to resort to 3% saline. Hopefully you would not require if you keep monitoring your serum sodium levels. So this is just the same that I said, water and sodium loss, replace isotonic fluid loss, and then water deficit. If it's pure water loss like DI, just replace water deficit. If it's increased sodium content due to ORS, 3% saline, you can use thiazide or loop diuretics, but always replace any water deficit. And this actually is very common in our ICU patients. When we want to, bring up the serum sodium, we are giving for SIADH, or when we have a patient with brain injury and we are giving 3% saline with diuretics, then we actually dehydrate the patient so much, also give so much salt loading with 3% that it overshoots and the serum sodium goes up to 165. So in such situations, you'll have to again give water, correct the water deficit, and use thiazides to remove all your sodium that you have iatrogenically administered. So in hypernatremia, thiazides actually are very useful. And in SIADH, loop diuretics help abolish your medullary fixed concentrating ability. Just briefly about another scenario where you can get hypernatremia, motor vehicle accident, traumatic brain injury, increased intracranial pressures. So this is a patient, polyuric, this is a patient who is developing central diabetes insipidus. So very low urine osmolality, basically losing tap water, no salts in the urine, and serum sodium is very high. So hypernatremia with polyuria and inappropriately dilute urine, this is DI. And you have to treat it with hypotonic fluid as well as to give vasopressin. Post-op craniopharyngioma is another situation where you get this triphasic response. So when there is a pituitary surgery, so initially you will have polyuria in the first few days, and that is very temporary. Then you have 1 to 3 days, you have a ADH, antidiuretic phase, and then you'll have the permanent DI. So in the first phase, you should not give too much so that the sodium can go up in the first 24 hours. But if you overcorrect it, then the second phase could become exaggerated and your serum sodium could drop very low because of all the fluid that you have given in the first phase. So this is your classic triphasic response, and so you have to be very watchful in your post-op craniopharyngioma patients. And of course, you treat with vasopressin. Sick patients in the ICU, you always give vasopressin infusion, and those most stable ones, you can give it as tablet or nasal sprays. So this is just a summary and a brief approach of all dysnatremias that you would encounter. Disorders of sodium are very common in critically ill patients. You have each individualized approach. More than one factor could be contributing to your sodium problems. And you should look at both the water balance as well as the intake of salts. And close monitoring is required. You have to monitor your serum sodiums at least 4th hourly in the initial period. If not, too early would be ideal. But you have to really keep a close watch of your serum sodium as well as your Glasgow Coma Scale clinical monitoring, because overcorrection could also cause life-threatening complications. Thank you.
Now all of you agree that even if you give bitter gourd, This lady will cook and serves with a very, very tasty sweet food. Thank you very much, Indira. Sir, Professor BRN, sir, you want to add anything to that, sir? Your comments?
I was just wondering, usually we say in the steep drop in the low sodium, hyponatremic conditions, and have CHS, we give them an IV, 3% saline, 3 ml per kilogram body weight.
I didn't get you, sir. Tell.
So, in severe hyponatremia with seizures, we give a rapid correction of 3% sodium chloride at the rate of 3 ml per kilogram body weight.
Yes.
What do you say about that?
Yes. So, if the patient is profoundly dehydrated, right, and he's also fitting and is breathing, you can give a little lower. You can give 3% saline, but you also need to correct the dehydration. So sometimes giving a lot of normal saline, which you need to correct, which you need for the dehydration and shock, may be equal to your 3% saline that you're going to give. So the amount of sodium in the fluid is more important than the type of fluid, whether it's 3% or it's isotonic 0.9%. If you're giving a lot of 0.9% normal saline, it will be equal to the 3 ml per kilo of 3% saline, but this holds good only in very dehydrated diarrhea patients. Otherwise, if a patient is symptomatic with low serum sodium, you will have to give 3% saline. You will have to give 3% saline because it actually, for the next 2-3 hours, you want the serum sodium to come up. You want the fluid to come out of the cells to reduce the cerebral edema and become less symptomatic. We are not chasing the number of the serum sodium, but we just want the patient to become less symptomatic, because when you give a bolus of hyperosmolar 3% saline, it draws the fluid from inside the cell and reduces the cerebral edema that the low sodium has caused. So it's more a symptomatic therapy rather than actually chasing a number. So yes, 3% saline will be required in all situations who are symptomatic hyponatremia, except in very, very dehydrated patients who will be anyway requiring a lot of isotonic fluid.
So Indira, you say that because in dehydration, hyponatremia, they need both water and sodium. When both are needed, normal saline probably is a better fluid than 3% saline.
Especially if you're anyway going to give a lot of normal saline, if the patient is not very dehydrated, but he still has low sodium, but that is a very rare scenario when he's not so dehydrated and has sodium and he's still having symptomatic hyponatremia. That's a very, very rare situation. In that situation, you may have to give 3%, but if he's profoundly dehydrated and you are going to give lots, 10 per kilo or 20 per kilo of normal saline, that is actually equal to a lot of 3% saline.
Thank you. So for a slow learner like me, probably in hypernatremia, the brain will shrink like a pickle, mango pickle kept in a salty water. Mango pickle shrinks to become a pickle. So brain shrinks in hypernatremia. In hyponatremia, you put a hard rice in water and boil, no? That hard rice will become puffed up, so they become edible. So in hyponatremia, brain swells up to cause cerebral edema. In hypernatremia, brain shrinks to cause intracranial bleed. Reverse occurs during correction.
Yes.
So I got some questions from the chat box. Because this question has come outside India, I thought I'll give priority for that. It is not exactly on sodium. They asked about the common cause of AKI worldwide. That is the question. Unrelated, but still we can answer. Anil Vasudevan requested answer. And Indira also can answer. Cause of AKI.
Part of the world the question is from, because there are, the epidemiology of AKI, there has been a shift of from a community to a hospital-acquired AKI based on the regional representation. So if you ask from a Western world perspective or from a city of a well-developed city perspective, many of the AKIs that come in are complicated or secondary to other organ dysfunction. So what we call a hospital-acquired or a non-infectious causes of AKI. While in the periphery, in the community, volume dehydration continues to be the most common cause of AKI. Second is infections, which could be tropical infections, could be lepto, it could be dengue, it could be malaria. Third is probably the over-the-counter use of NSAIDs and native medications. I think community-acquired AKI, these are the common causes, while in a hospital-acquired AKI, it is probably multifactorial, including septic shock, organ transplants, and the multiple use of antibiotics, and so on.
Indira?
I think Dr. Anil has already given the
Completely.
full spectrum. Hypovolemia is something that, very common. So I think diarrhea, uncorrected dehydration, that is extremely common. And on top of that, if you give NSAIDs and nephrotoxic drugs, it becomes a double whammy to the kidney.
Okay, I have some difficult questions to you, to Anil Vasudevan sir. When you are not including urea, I think you're saying that it is not useful for effective osmolarity. And why do you use this for osmolarity calculation?
So it is a partially effective. It is freely it can be transported across the membrane, but in a very high concentration, it does have some tonicity effect.
Okay, Indira, you told one word used, the pilfered doughy feeling. What is that? What is that word which I forgot? What is that feeling? Doughy feeling. You heard some word to that.
So it's like dough. I think it's
doughy feeling.
Doughy feeling, because your fluid is still maintained, even though a patient with hypernatremia is dehydrated, has lost a lot of fluid. Yeah, but because of the
Pilbury, you said you used the word pilbury, doughy feeling. What is it, pilbury?
Pilbury. So it's basically a dough like what do you say, chapati, roti, pilbury dough. So it's the dough that you feel. Because the ECF is still maintained, your fluid from your ICF inside the cells has moved to your extracellular compartment because of the high osmolarity outside your cells. And so you don't look so dehydrated, even though there's a lot of water in the body. So that's your doughy feeling.
So Bjorn also used to compare this with atta mavu, this maida mavu. When you feel that maida mavu will give that feeling.
Name
Chapati
of the
making. That
name of the dough. Yeah.
Then another question is, the difference between, again, is it a play of English or really? That is, what is the difference between pseudo hyponatremia and factitious or fictitious hyponatremia? Is it just an English word, or what exactly it means?
Well, it is used
from our students.
It is used interchangeably, but pseudo hypernatremia is actually your the proteins, lipids, etc., that cause a lab error and cause hyponatremia. That's a lab error. So that's pseudo hyponatremia. Factitious is your hyponatremia caused by mannitol or by hyperglycemia, the osmolar. So, but they are used interchangeably. So factitious is for hyperosmolar situations, and pseudo hypernatremia thing.
In fact, it is more.
So can I say that normal? Yes, sir. Yes, sir.
Use it by cop and lab error. Laboratory gives a wrong.
So flame photometry.
All of the conditions, so some cause. So we call the pseudo.
Okay, only the flame photometry causing hypernatremia is called as factitious or pseudo?
No, lab error. The way they calculate.
Okay. In dengue,
very delicate.
in dengue, third space occurs when there is a leakage into the third space. Why it results in hyponatremia, not hyper? Third spacing, the sodium disturbance is hyponatremia. Why not hyper?
Probably there is also loss of your sodium. Salts also get move along. So there's so much of endotheliopathy, the entire plasma along with your salts also leak. So in pancreatitis is one condition where actually you have more of, the fluid. That causes hemoconcentration. Dengue also causes, but you probably have a lot of sodium loss.
Again, a slow learner like me, the free water loss should have been ideally called as electrolyte free water. It took a long time for me to understand that they mean electrolyte free water. I was looking at it, why free water? Where is free water? So it should have been properly termed as electrolyte free water for all of us to understand. And there is another question for Anil Vasudevan. If there is a minimal increase in the ECF volume in SIADH, why is still categorized as euvolemia?
So clinically, they may be euvolumic. You hardly find them hypertensive. You hardly find them edematous, that intravascular thing. So that's a tough call, and that many a times used to be misleading. That's why they have this reverse clinical association where you look at osmolarities and urine chemistry and then correlate with the examination. So if the weight is, and the other sensitive marker rather than examining them is the weight gain. So that typically happens in marathon runners, where actually after marathon, instead of losing weight, they gain weight and they have a hyponatremia. So typically they have increased intracellular volume and a decreased extracellular volume, a classical pathophysiology of hyponatremia. So weight will be a more sensitive indicator rather than a clinical examination for the volume status. And as I said, it's very difficult in an SIDH to document hypervolemia, which is, as you said, is not very dramatic.
So Professor BR, any comments before concluding? Concluding comments?
No, fine. I think really well prepared and well got up and well presented presentation. Hypo, I think the most difficult harrowing part. The more you listen, the more you feel. Today, both Anil and Dr. Indira really impressed us. Yes, something. How there's a small thing. How the small head could hold so many facts. Congratulations to both.
Thank you, sir.
Kalivani, anything you want to add?
Yes,
Kalivani?
I think they have covered everything, so nothing to be added. Since
It's really fascinating. So next time when I take the salt to add to the rice, probably I will look at all these graphs and probably I'll throw it again into the bottle. Probably that is the advantage we are going to learn from this. Thanks a lot. You beautifully covered right from basic to complicated clinical scenario. It's great of Professor Anil Vasudevan and Professor Indira Jayakumar. We're all much thankful to you for your scientific elaboration. Thank you very much, Professor BR, and thank you very much, Kalevani. And then I just announcement every Wednesday and Saturday this is going to happen. By next 16th, we have an interesting talk on hypertension. Is it? Hypertension emergencies. Every Wednesday and Saturday, you will listen to this from 7:30 to 9 or 9:30. It goes up to the December 2nd week. Thank you very much. I thank everybody.
Good night. Thank you.
Thank you very much. Bye.
Thank you
We'll
so
meet
much,
again.
sir.
We'll meet again on Saturday.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you very much.
thank you, sir.
Good luck to Indira and Anil.
Thank you, sir. For me, sir.
Thank you, sir.
Thank you, sir.
Yes, sir. Thank you, sir. Thank
Thank you.
you,
Thank you.
sir.
Hello. Hello.
Hello.
Hello. Siddharth sir.
Siddharth. Follow this side. Siddharth.
Should I close it?
Yeah, we can close it now.
Okay.
Stop the recording, Chadil.
Yeah. Okay.
Hello. Hello.
Yes, sir.
Jatil bhai, thank you. Thank you very much.
Thank you, sir.
Saab